Hello, everyone, and welcome to Henry Schein's series on COVID-19 on YouTube. I'm Dr. Gary Severance with Henry Schein, and it's my pleasure to welcome Dr. David Reznik, who will be updating us on all things related to the recovery from the pandemic, including, are we seeing signs of recovery from the latest variant? Dr. Reznik, welcome.
Good day, everyone, and thank you, Gary, for the introduction. As always, it's a privilege to be able to share some information. This time we have a few things that I want to go over. I basically want to look at where we are with community transmission. We know that Omicron has literally taken over in the United States. We are seeing some parts of the country which have reached their high level and they're starting on their way down. We have other parts of the country where we're still building up. And so this isn't quite over with yet. But we should be familiar with the Omicron wave and whether the U.S. is following a pattern seen in other countries where you have these rapid rise in the number of cases, such as in South Africa. And then you saw, once it peaked and it plateaued, you saw a rapid decrease. So is that something that we're going to be able to see in the United States? Taking into consideration we're an older population and a much larger country. We're going to look at the vaccination rates in the U.S. And what do we mean by saying you're vaccinated, and what do we mean by saying that you are up to date with your vaccines, which is a new term that I'll be going over because that does involve the booster rates that we have in our country. We do know that if you're boosted, your chances of getting a serious illness and ending up in the hospital or an ED are greatly reduced. We're going to look at the effectiveness of the third dose of the mRNA vaccines. There's been some mixed messaging about that. And so what I tried to do for today's presentation was bring up 3 different unique studies with large patient populations where we could see whether or not this boosting dose of the mRNA vaccines is really giving us the kind of protection we need to eventually go into a form of normal. And also at the time of this recording, we know that Pfizer is working on a booster that is specific to Omicron and others. We know we can't just constantly get boosted every 5 months. And the whole goal is getting a vaccine that maybe we can do once a year. And then I think what affects our practices and how we're able to maintain the remarkable levels of care we provide on a daily basis is looking at CDC's interim guidance for managing healthcare personnel with SARS-CoV-2 infection after an exposure. So I think these are some of the main topics we'll cover. So let's get going. So if you look at the community transmission in the United States by county, there are only 4 counties that have low community transmission in the entire United States. 99.78% are in bright red, which means it's high community transmission. We have one orange county that you can see up in, looks like possibly Montana, that is substantial, but for the most part, the entire continental United States and Alaska and Hawaii are all in a high level of community transmission as we are. Now, when you start seeing the numbers come down, it's important to know that, yes, we see people getting sick and going to the hospital and the EDs. And if you turn on the news, you can see how overwhelmed some of our hospital systems have been. But when it starts to go down, when the peak starts to go down, we're still getting new cases. So we're not out of the woods when the peak is reached and we go down, but it's a great sign that it's finally working its way through the population. More and more states have passed the peak, and I think that's really important. We've seen it in New York where they passed the peak, and Massachusetts where they passed the peak. And even now in my home state of Georgia and in my hospital, we apparently have passed the peak, which is truly important. By the end of last week, the country was actually averaging about 720,000 new cases, which was a pretty significant reduction from the week before. And I feel that we're going to continue to see these reductions as we move through the end of January and through February. But even as the hopeful data points come, the threat has by no means passed. And that's why I'm really trying to push the fact that we still need to maintain safe. But before I get there, I really want to talk about how well dentistry has done in protecting our patients and our staff. You're not hearing about these big outbreaks in dental offices or large dental programs. Our protocols that we have in place before dealing with bloodborne pathogens, very effective. The protocols we have in place now dealing with airborne pathogens, very effective. So as long as we maintain what we're doing, we're going to be fine. But we still are seeing more cases and more infections a day than in any other surge. In some states in the West, in the South, and the Great Plains are still seeing sharp increases. So where you might see a part of our country starting to go down, other parts of the country are going up. As I mentioned before, many hospitals are full. I can't remember the last time that Grady Hospital, Grady Memorial, which is where I work, was less than 100% full. We have been over 100% capacity for, it seems like, 6 to 8 weeks. Deaths continue to mount. Remember, infections are one way that we see where the cases are going. Deaths come a little bit later. We are seeing deaths, and more than 2,100 were announced almost every day. So it's still a problem. 865,000 people have passed away from SARS-CoV-2, which is a very, very sad number. If you look at new hospitalizations and new ICU admissions and new COVID hospitalization levels, you're looking at the numbers are really truly starting to peak. So if you look at the new COVID hospital admissions, like I said, even at my hospital, which has been hit so very hard by COVID, we are beginning to see a decrease in the number of new COVID hospital admissions. We're also seeing a plateau on the number of people who are hospitalized. And you can see what a remarkably sharp increase there was in new COVID hospitalizations from December through January, through new admissions, through hospitalizations. And then the number of people in ICUs, again, it seems to be flattening out to a degree. Notice that the COVID patients in the ICUs isn't as sharp an increase as we're seeing with hospitalizations and new hospital admissions. And that's primarily based on the lack of severity of this particular variant. And I think it's important to go over that people who are passing away have multiple comorbidities. They do tend to be older, but it doesn't mean they're the only people that are impacted by this virus. If you look at by the parts of the country, so you can see here on new COVID hospital admissions, the Northeast really is reached their peak and they're heading in the right direction. The South, we started a little bit later. Our peak was a little bit sharper, but we got up to the levels of the Northeast. We're just beginning to see a drop in our cases. The Midwest, again, beginning to see a drop in certain parts of the Midwest, but the West is still on the way up. If you look at, again, on hospitalizations related to COVID, the Northeast had a very high number, but it's beginning to go down. The South is still on an incline, moving in the upper direction, but beginning to flat down. The West is catching up. And all of these, and even if you look in the ICU, I think one of the issues that we see here is how many people in the Midwest are in the ICUs relative to the other parts of the country. The South, again, we're catching up. And it's probably a lot to do with who is vaccinated and who is not, who is up to date with their vaccines and who is not. And so in the South, there is a lot of vaccine hesitation. In the Midwest, there are certain areas of our country that have a lot of vaccine hesitation. And we just have to do better with helping our patients, those we serve and those we work with, about the benefits of being vaccinated against this illness that will put you in the hospital if you're not vaccinated. 75% of our hospitalizations, at least in my hospital, are unvaccinated individuals. Only about 10% are breakthrough. So they might have had one injection, but not the second dose, et cetera, et cetera. So this is what we're seeing at Grady Memorial. You can see the numbers and July 1, when everything was looking good, the numbers were low. And as summer started, we started to see a little bit of a peak. And then in December, it's like, wow, we're really down to like 18 people in the hospital. We took a sigh of relief. Everything was looking good. And then you can see what happened from basically after our last clinical update until where we are now. So we were getting close to 300 patients in the hospital with COVID. That was the highest number we have seen since the start of this pandemic. Gratefully, that number has peaked and it is continuing to drop. And we're seeing what they saw in the Northeast. We're seeing a pretty significant drop. So at one point where we were at 290, I believe yesterday we were down to 225. And every day we're seeing these significant very favorable decreases in the number of people being admitted to at least our public health hospital in Atlanta. And so I think it's important to go over national information and regional information, but because I have hospital specific information, we can actually look at actual numbers of people who are in the hospital and who are being discharged. So let's talk about vaccination status. There are 210 million people who are fully vaccinated, which is pretty darn good. That's really done well. But only 83 million people have received a booster dose. So that is something that we need to work on. One dose is really, truly not effective. And if you've heard me talk about this before, I don't even know why we track it. Because one dose is not going to give you protection against Delta. It's not going to give you protection against Omicron. And so why we put these numbers out there is to show you the percent of people that have had one dose and then where we are as far as being fully vaccinated. So at this point, the total number of people with one dose is over 75%. People who are 65 years of age and older have done a better job. They're at 95%, at least having one dose. If you look for our fully vaccinated people, you can see fully vaccinated in the United States is about 63 to 65%. Over 5 years of age, because remember, we don't have a vaccine under 5, so greater or equal to 5%, the number is higher at 67%, but we can do better. Greater than 12, 72%. Greater than 18, 74%. We can do better. We really need to follow the example of those most at risk, which are our elders, those people who are 65 years and older. They have 88.2% are fully vaccinated because they're at risk, and we do want to keep our families healthy and we want to keep our staff healthy. I have a dentist on my staff who is greater than 65, and I make sure that we go and get our vaccines and our boosters at the same time. And we've been doing this throughout the process. Booster doses. This is really where we need to do better. On our booster doses, if you look total, it's less than 40% have been boosted. If you look at the population greater than 18%, it's around 43%. Greater than 50, it's about only a little bit more than half. And greater than 65, it's at 63%. You need to be up to date with your vaccines to get protection against Omicron. So we have a significant percentage of our population that is still at risk. And vaccines alone don't really get it because it's not going to stop you from getting infected, which is why we're still wearing masks in crowded indoor settings. I'm getting ready to go to the airport tomorrow. I will have my mask on from the time I get into the airport and to the time I step out of the airport when I land in Boston. So we really need to take all the precautions that we can. There will be masks that are being mailed out to folks. There are tests that are being given out to folks. We really need to do what we can to stay safe and to keep those in our family who are at risk safe as well. If we talk about eligible people who are booster eligible but have not been boosted at this point, we can see on total it's a little bit more than half the population. And we have a significant number of people who are 65 years and older who have not been boosted. So, and a group that I'm in, the greater than or equal to 50 years. I wish I was closer to the 50. It's about 42%. So we have a lot of people who need to get up to date with their vaccines. These vaccines do work. So if you look at the rates of COVID-19 cases and deaths by vaccination status, people who are unvaccinated, of course, have a greater risk of testing positive, greater risk of dying, greater risk of showing up in an emergency room, greater risk of showing up or being hospitalized. Unvaccinated people in every age group had higher case and death rates compared to fully vaccinated people in the same age group. Vaccines work. Case and death rates for people fully vaccinated with any of the three types that are available in the United States, whether at Moderna, Pfizer-BioNTech, or J&J Janssen, were much lower than for unvaccinated people. So it's truly important that we get everybody vaccinated and we get people up to date with their vaccines. People who were fully vaccinated with an additional or booster dose had lower case rates compared to those without. This makes common sense. Both groups had much lower risk of testing positive for COVID-19 and a lower risk of dying for COVID-19. People ages 65 and older had a larger benefit from receiving the additional booster dose compared with those that were between 50 and 64. So I have older people in my family. My brothers are both older. I want to make sure that my family, that my aunt and my uncle, those who are most at risk, stay healthy during this part of our pandemic. And hopefully, this will be the beginning of the end. I'm not making that statement. I don't know because variants can pop up. There's already a variant of Omicron that is out there that we're seeing in some certain parts of the world. We still don't know enough about it, and it's just a variant of interest at this point. It's not a variant of concern. If we look at the death rates, and this is what this screen shows you, you can see early on we were seeing a great number of deaths, but it's important to note that we have seen more people die from COVID in 2021 than we did in 2020. And we're really talking about the anniversary now of our patient zero, of the first case we had in the United States was basically 2 years ago this week. And so we still have a pretty significant death rate. Our goal and what we think is going to happen as Omicron works its way through the country, as the death rate will continue to go down. So we're still sort of at a high number, but we're hoping that the number will start to go down in a positive direction. If you look at rates of COVID-19 cases by death, cases and deaths by vaccination status, if you look at those who are fully vaccinated, their incidence per 100,000 of the population was significantly lower than those who were unvaccinated. So look at the blue line. Yes, there was an increase. You can get infected with Omicron if you're fully vaccinated, but chances are you're not going to be all that sick. You're not going to end up in a hospital. You're not going to end up in urgent care. You're not going to end up in an ED. If you look at fully vaccinated and the death rate, you can see how the death rate literally stayed flat. That blue line is flat. But you can see the unvaccinated rate had a higher incidence of deaths per 100,000, and that number is still going up because remember, cases go down first, death rates go down later. Are you up to date? And instead of changing the definition of fully vaccinated, our definition of fully vaccinated as it stands today is one shot of the J&J. Fully vaccinated would be the 2 doses of Pfizer or the 2 doses of Moderna. So are we up to date? Up to date now considers getting a booster once you're eligible. So if you had J&J 2 months after you got your original vaccine, you are eligible to be boosted. If you got Pfizer or BioNTech 5 months after you have your last dose, you can be boosted. And right now, that's where we are. So CDC's COVID data tracker shows that of January 20th of this year, more than 209 million people have received their primary series. So they are definition-wise fully vaccinated, and they're considered that. But more than 82 million people are what we call up to date. So they have received their booster. So they have much greater protection than those who are fully vaccinated. So they up to date means you have received all of your recommended COVID-19 vaccines, including the booster. based on new CDC data showing if you don't get boosted, after 6 months in this case, the two-dose mRNA vaccine is only 57% protective against hospitalization and 38% versus going to the R versus Omicron. So just being fully vaccinated doesn't keep you out of our hospitals and doesn't keep you out of the ER. But if you get boosted, you are 90% protected against hospitalization and 82% respectively against an ER visit. So just using common sense, getting up to date with your vaccine will keep you out of the hospital. And if you look on the news, you can see the ICUs are full in many parts of the country. Missouri is really going through it right now. Our ICU at Grady, we were full up into a few days, several days ago. So we still are having these hospital crunches. And our frontline emergency department workers, our frontline people, our nurses, our physicians, our advanced practice providers, they really have been under the gun now for 2 solid years. We have done a great job with our infection control protocols, but we still need to make sure that we keep up the level of protection that we have done since the start of this pandemic. So what about the effectiveness of a third dose? There have been of an mRNA vaccine. There have been some studies out there and some Facebook information saying it really doesn't help. So I'm going to give you just some brief summaries of 3 different studies showing that these mRNA boosters are very effective. So what do we know? We know that COVID-19 mRNA vaccine effectiveness, or VE, in preventing COVID-19 might decline because of waning vaccine-induced immunity or variant immune evasion. We know that Omicron can actually evade the immune system. So vaccine effectiveness was significantly higher amongst patients who had their second mRNA dose within that 6-month period of time before medical encounters compared to those who waited longer. During both the Delta and Omicron predominant periods, receipt of a third vaccine dose was highly effective at preventing COVID-19 associated emergency department and urgent care encounters, 94% and 82% respectively, and preventing COVID-19 associated hospitalizations, 94% and 90% effective. So we do know that getting boosted by mRNA vaccines will keep you out of the hospital and it keeps you out of urgent care, out of an ED. And now is not the time you really want to go to an emergency department because they're overwhelmed in many parts of our country still. What are the implications for our public health practice? All unvaccinated persons should start vaccination as soon as possible. This is not a political issue. This is a health issue. This is a public health issue. And as trusted public health providers, and that's what we are in the dental community, whether you're a dentist, a dental hygienist, you work in the office, whatever role, we are trusted by our patients and have been. And so we can talk to our patients on why it's important to get vaccinated, not only to protect themselves, but other members of their family. All adults who have received mRNA vaccines during primary COVID-19 vaccination series should receive a third dose when eligible. And eligible people should stay up to date with their COVID-19 vaccination. So when you're listening to this presentation, being up to date would be 5 or 6 months after you've had your primary dose and you've had your booster. And I think most of us on this on today's webinar have actually been fully vaccinated, and hopefully most of us on this call are up to date with our vaccines. So again, we're going to look at COVID incidence and death rates among unvaccinated and fully vaccinated adults with and without booster doses during the periods of Delta and Omicron. Remember, we were dealing with Delta, and then all of a sudden it just became all Omicron, and Delta sort of went away, which is actually pretty good because Delta caused a more severe illness than Omicron does, even though we do have our hospitals full of Omicron patients now. So what do we know? Although COVID-19 vaccine effectiveness decreased with the emergence of the Delta variant and waning of vaccine-induced immunity, protection against hospitalization and death did remain high. So what did this study, a new study, show us? Protection against infection and death during the Delta predominant period against infection during the Omicron emergence were higher among boosted vaccine dose recipients, and especially amongst those greater than age 50. So again, those who are most vulnerable, and that has to do with aging. It also has to do with underlying medical conditions, such as those with diabetes, such as those with certain other underlying medical conditions, who don't have a great immune response. It really is important to make sure that our patients are boosted. So during the emergence of the Omicron variant, being up to date with COVID-19 vaccines provided a certain level of protection against infection. Adults who are unvaccinated have a 5 times higher risk of infection compared with adults who were fully vaccinated with a booster. So up to date. Association between 3 doses of mRNA COVID-19 vaccine and symptomatic infection caused by SARS-CoV-2, Omicron, and Delta variants. So what was the question? What's the association between 3 doses of mRNA vaccine and symptomatic SARS-CoV-2 infection with Omicron and Delta variants? Among individuals seeking tested for COVID-like illness in the US in December 2021, the receipt of 3 doses being up to date compared with unvaccinated, and only those who were considered fully vaccinated or 2 doses was less likely among cases with symptomatic SARS-CoV-2 infection compared with test negative controls. Again, we're getting increased protection if we get boosted, if we're up to date. These findings suggest that a receipt of 3 doses of the mRNA vaccine relative to being unvaccinated to receipt of 2 doses was associated with protection against both Omicron and Delta variants, although higher odds ratio for Omicron suggests less protection for Omicron than Delta. We know that Omicron can evade the immune system to a certain degree, but getting boosted does still offer us significantly more protection. Why it's important that we look at this. And this was from a Journal of the American Medical Association study that was published just in January 21. And actually, there is even another study of 4. A new British research confirms that boosters can neutralize the Omicron variant, and that's important. Researchers analyzed 620 blood samples from 364 healthcare workers and staff from the Francis Crick Institute and the National Institute for Health Research Biomedical Research Center in London. People who had received only 2 doses of either what they were using, AstraZeneca, or the Pfizer vaccine, were less protected against Omicron variant than against the Alpha and Delta variants. So we know that this one can evade the immune system to a degree. Antibody levels declined in the first 3 months after the second dose, but a third booster dose increased levels of antibodies that combat the Omicron variant. So again, if we're dealing with Omicron now, we need to have up-to-date vaccine status to be able to offer protection. During the week ending, and this is again, it's hitting our nursing homes again. And if you look at people's vaccine status, and you look at people who work in nursing homes, we really have to do a better job in getting those individuals, our caretakers, vaccinated. And there might be barriers that they seek to getting vaccine, and you might be able to be the person or the people who are going to help them get over their fear of this vaccine and get vaccinated. But during the week of the January 9th, U.S. nursing homes reported more than 32,000 COVID-19 cases and regretfully 645 deaths amongst residents. This is a 7-fold increase in cases from a month earlier and a 47% increase in deaths. So again, if you have older members of your family, getting them boosted is really what we can do. It's heartbreaking when you look in the news and you see people that would make the news that are passing away from this when it's preventable, or you and your family are dealing with a death based in something that we could prevent to a large degree. About 57,000 nursing home workers also had COVID-19 that same week, and that was a tenfold increase from a month earlier. This is in information, nursing home data that the CDC tracks. Vaccination efforts may have made a real impact in saving lives. Even with the dramatic increases in cases, the death toll from COVID-19 at nursing home is still a fraction of what we saw in December of 2020, when the CDC says there were around 6,200 deaths. Every life is an important life. So where I bolded the 645 deaths amongst residents in nursing homes, which could very well have been a family member of somebody on this call, compared to where we were in December of 2020, we really are doing a much better job. And partly because we do have a lot of people who are fully vaccinated, and partly because Omicron still can cause a significant illness, but not as often as you would see with the Alpha or Delta variants. So what about the interim guidance for managing healthcare personnel with SARS infection? Somebody tests positive, what do we do? So due to concerns about increased transmissibility of Omicron, the interim guidance is being updated to enhance protection for healthcare personnel, patients, and visitors, and to address concerns about potential impacts on the healthcare system, given a surge that we've been dealing with. Up to date, I'm saying it again, means a person has received all recommended COVID-19 vaccines, including any booster doses when eligible. Fully vaccine means a person has received their primary series, and there's the sourcing for that. In general, asymptomatic healthcare professionals who have had a high-risk exposure do not require work restrictions if they are up to date with all recommended COVID-19 vaccine doses and do not develop any symptoms or test positive. The duration of protection offered by a booster dose of vaccine and their effect on emerging variants still is not clear, and we keep on following this very, very closely. As I said, we have one of the major companies, Pfizer, looking at a vaccine that will be specific against Omicron. But even the CEO of Pfizer has stated we can't boost people every 4, 5, or 6 months. It's just not something that's going to work. We really need to find a vaccine that is going to cover us on an annual basis. And then again, what are people testing positive for? So there are actually point of care tests that are available today that can look. So if I have a patient I suspect may have COVID. We not only run a COVID test on them, but we also run for the regular flu A and B types. So we're really looking at what is causing this because symptoms can be similar. And there are point of care tests that are available that you might want to put into your practice at some time in the very near future. Healthcare workers with even mild symptoms of COVID-19 should be prioritized for viral testing with nucleic acid or antigen testing. Antigen testing lets you know if you're infected at that moment. Nucleic acid testing can actually stay positive for several months later, just to non-infectious viral particles that are still present. So we want to ensure that SARS-CoV-2 testing is performed with a test that is capable of detecting SARS-CoV-2 even with the current circulating variants in the US. When a clinician decides that testing for a person for SARS or COVID-19 indicates negative results from at least one FDA emergency use authorized COVID-19 viral test indicates that the person most likely does not have active SARS-CoV-2 infection at the time the sample was collected. So you could be tested today and have a negative sample, but if you put yourself at risk tomorrow, you could be affected then. And so that's why it's important that we maintain all the safety protocols we have put in place. A second test for SARS-CoV-2 RNA may be performed at the discretion of the evaluating clinician, particularly when a higher level of clinical suspicion for infection exists. And so an example, following a negative antigen test on a person with positive symptoms. Consultation with an infectious disease expert should be considered to resolve any discrepant results. That is a blessing that I've worked with infectious disease physicians and infectious disease advanced practice providers for over 30 years. So getting a consult in my environment is very easy. It might not be as easy in your environment, but there are infectious disease physicians throughout the United States, people that you can call and try to find out the information that you need, whether somebody is infected or not. Local resources are always great resources. The following criteria are to determine when healthcare professionals with SARS infection can return to work. Either an antigen test or nucleic acid amplification test or NAT testing can be used. Some people may be beyond the period of expected infectiousness, but still remain positive for NAT testing, like I mentioned. This is actually due to non-infectious viral particles. Antigen tests typically have a more rapid turnaround time, but are sometimes less sensitive than NAT testing. Antigen testing is preferred if testing symptomatic healthcare professionals who have recovered from SARS-CoV-2 infection in the prior 90 days. So testing is important. Antigen testing is a way to find out if somebody is infected, but if you're not clear and their providers are not clear, again, the goal is to contact an infectious disease physician. Healthcare professionals with mild to moderate illness who are not moderately to severely immunocompromised, how long do they stay out? At least 7 days if a negative antigen or NAT test is obtained within 48 hours prior to returning to work, or 10 days if testing is not performed or positive test at days 5 to 7 have passed since their first positive viral test. At least 7 days if a negative antigen or NAT test is obtained 48 hours prior to returning to work, or 10 days if not performed, if not having a test have passed since the symptoms first appeared. So again, your first day is day 0 when you test positive, and then they're talking about waiting 7 days if you have a negative test, or 10 days if no test was performed or you had positive at days 5 to 7. We were hearing about coming back earlier. Those situations where we have people come back earlier, like 5 days, I'll talk about, but that's really for hospital-based workers, for emergency department workers, for urgent healthcare professionals. That really doesn't apply to dentistry at this point. At least 24 hours have passed since last fever without use of a fever-reducing medication. That has not changed at all since our initial guidance came out over a year ago, and symptoms have improved. You can maintain a cough for a long period of time. You might have a little bit of shortness of breath, but you want symptom improvement, no fever within 24 hours, at least 7 days of a negative antigen test was performed within 48 hours of returning to work. And if you don't have, again, 7 days from their positive viral test. Healthcare workers who are asymptomatic throughout their infection and are not moderately or severely immunocompromised, because if you're moderately or severely immunocompromised, you will stay out longer. At least 7 days of a negative antigen test or NAT test is obtained within 48 hours prior to returning to work, or 10 days if testing is not performed. This is not any different than we talked about before. So we're talking about asymptomatic versus symptomatic. At least 7 days that healthcare worker would need to be out if a negative antigen test or NAT test is obtained within 48 hours prior to returning to work. Healthcare professionals with severe to critical illness and are not moderately to severely immunocompromised, at least 10 days and up to 20 days have passed since symptoms first appear. At least 24 hours have passed since their last fever without use of a fever-reducing medication. Symptoms have improved. Test-based strategy as described for moderately or severe immunocompromised healthcare professionals below can be used to inform duration of isolation. So again, it's about how long does somebody need to be isolated at home. So what do we talk about when we're talking about for guidance? What's the definition of a close contact? Being with 6 feet of a person with confirmed SARS-CoV-2 infection for 15 minutes or longer during the course of 24 hours. So it's not like having a 15-minute conversation with someone in my office. I could be around that person for a total of 15 minutes within 6 feet. Having unprotected direct contact with infectious secretions or excretions of the person confirmed with SARS-CoV-2 infection. Distance of more than 6 feet might also be of concern, particularly when exposures occur over longer periods than 15 minutes, or you have poor ventilation, Remember, one of the things that we look at with infection control is having good ventilation, having techniques to address the aerosol when you're doing aerosol generating procedures, whether it is using high volume evacuation, a rubber dam, whether you're using extra oral evacuation kits or you have HEPA filtration or UVC. All of these things are very effective in reducing aerosols. When close contact occurs, factors that can reduce risk for transmission include correct use of personal protective equipment. So wearing your N95s correctly, wearing your KN95 if that's what you're wearing correctly. Remember, the CDC initially said that it's N95 plus a face shield or eye protection. For those that can't wear N95 due to asthma or breathing concerns, a face mask is considered okay. It's not a respirator as long as you have your eye protection and face protection. Last month, I talked about the bacteria that you can actually see on the forehead when you don't wear a shield. So that's why I'm a big believer in wearing face shields. Not just you're protecting your eyes, but you're also protecting your face because the number of times our hands touch our face and go to our mouth is significant. Use of well-fitting source control by the individual with SARS-CoV-2 infection. Cloth masks are not the deal. When I have people coming in with cloth masks today, and I work at a program that serves low resource individuals, I actually give them a few face masks. I don't give them our respirators, but I do give them some face masks to wear under their very stylish cloth masks, because cloth masks are not offering enough protection. And whether or not the healthcare professional or the individual SARS and COVID-2 are up to date with all recommended COVID-19 vaccine doses. So we had a patient that ended up testing positive. They came in the morning. They were tested for SARS-CoV-2 in the morning. We saw the patient later that morning for an aerosol generating procedure, but my staff is up to date with their vaccines. They're all wearing fit tested N95s. Remember, you have to be fit tested on an annual basis, or every time that you change your mask, your respirator, to a different brand, you need to be fit tested again. And so we do that here. And so the fact that we have HEPA filtration and extra oral aerosol protection, and we use rubber dams, there was no concern that we were going to transmit in the dental setting, even during this highly infectious period of Omicron. Higher risk exposures generally involve exposure to a healthcare professional's eyes, nose, or mouth. And so I see patients coming in all the time wearing chin masks. They're covering their mouth, but they're not covering their nose. Our staff really needs to make sure that they're wearing their proper PPE at all times when they're in the clinic portion. My big concern is lunch, and where people are eating in groups. So we do social distancing during lunch. We try to have people in different areas during lunch. So we're not going to have someone who is asymptomatic, because a lot of these infections are asymptomatic, infect the rest of the staff. So remember, if you're in the room, get tested N95, face shield or glasses. Make sure you have on your gloves, your disposable gown, your surgical gowns, just everything that we have been doing for the last 2 years. Contingency and crisis strategies are really for hospitals, and I'm getting ready to go over that in a moment, and that's to mitigate healthcare personnel shortages. The United States is facing a significant shortage of nurses. And we actually have a shortage of dentists in certain parts of our country. But nursing, we have a significant shortage. We have a lot of people who are leaving their jobs, and they're burned out from having to deal with this for 2 solid years. We have issues with having enough respiratory therapists. We have issues, are there enough medical assistants to be able to manage what our hospitals have been facing? And all you have to do is turn on the evening news, and you can see what parts of the country are just completely overwhelmed with this particular strain. So there is important to point out that there is a difference between my hospital's environment and that of a general dental practice. So using the crisis and contingency strategies are really not meant for us. These are meant for hospital-based programs. So what are they? So up to date, again, with recommendations. So stay up to date with your vaccine. And this really goes over your work restrictions for conventional. It's 10 days or 7 days with a negative test. I think that word's a little bit easier and makes it a little bit more simple to understand. If asymptomatic or mild to moderate illness with improving symptoms. Contingency, which is what we have going on in our hospital right now, is 5 days with or without a negative test if asymptomatic or mild to moderate illness. Crisis, no work restrictions. We are not in crisis mode at this point. We came very, very close earlier this month. Work restrictions for asymptomatic healthcare professionals with SARS-CoV-2 exposures, they're up to date. For conventional, just an exposure, no work restrictions with negative tests on day 1 and looking at testing on between days 5 and 7. Contingency and crisis, no work restrictions. Again, this is about our overwhelmed hospital systems. I mean, for the first time that I have been in Atlanta, we had the 6 major hospital organizations release a joint statement together saying, please get vaccinated. Please wear your mask when you're in indoor settings, because we were at the breaking point. If people are not up to date with their vaccination status, again, it goes to 10 days or 7 days with a negative test. But under contingency and crisis, no work restrictions with a negative test on day 1 through 3 or 5 through 7. If shortage of tests, prioritize days 1 to 2 and 5 to 7. And the testing, you can sign up to get tests into your home now from the federal government, your tax dollars at work. I signed up. I want to make sure that if I go and visit family, if I'm getting ready to go on a plane, that I am not going to infect my family. No work restrictions under crisis mode. So the bottom line is looks like a significant part of the country is beginning to see a downturn in Omicron. We are not out of it yet, but unlike the December presentation where I felt like I was adding coal to your stockings because Omicron was getting ready to hit, I'm in a much more positive place at the present time. I think we're going to see certain areas in the next month before our next webinar where everybody is heading in the right direction, that we're basically talking about Omicron as something that we are successfully dealing with, that if we were to do an online poll, most of the people on this call or who are watching this video would be up to date with their vaccine status, because we want to keep those we work with, those we treat, those in our family, we want to make sure that they stay healthy, they stay happy, and that we don't have any untoward outcomes. As always, we look forward to any kind of topics that you'd like to bring up in the future or questions that you have. I do address questions that come into the webinar at henryschein.com. And with that, I'm going to turn it back to Dr. Severance. Again, thank you for your time and attendance. It's always a privilege to be able to speak with you. Gary?
Thank you, Dr. Reznik, for the continual updates. And thank you for watching. Please email us any questions, concerns, or requests for future topics at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. And to be notified of any premieres, click the bell icon. Thank you once again for your attention. Please stay safe and stay informed.